Hello everyone, welcome back to my channel. So today we are going to study about esophageal tumor. Any tumor is divided into benign and malignant. So in this esophageal tumor, we are going to study about malignant esophageal tumors and benign. So in the benign, it includes GIST tumor, and the full form of GIST is gastrointestinal stromal tumor. Second is leiomyoma. Third is fibromas, and fourth is lipomas. In the malignant tumor, we are going to study about the squamous cell carcinoma and adenocarcinoma. And in the recent history, incidence of adenocarcinoma are increasing rapidly. But the most common tumor is squamous cell carcinoma. So we are going to study about the differentiation of squamous cell carcinoma and adenocarcinoma. In squamous cell carcinoma, it is predominant in male, but in adenocarcinoma, it is both equal in males and females, and they are present in the western areas. Squamous cell carcinoma is present in the upper and middle third of the esophagus, but adenocarcinoma is present in the lower third. Risk factors includes associated with betel chewing, tobacco, achalasia cardia, alcohol, Plummer-Vinson syndrome, which is associated with iron deficiency anemia, and VEPs are present. And celiac disease. Celiac disease is sensitive, the person is sensitive to gluten. In adenocarcinoma, the risk factors includes Barrett's esophagus, tobacco, obesity, and H. pylori. Clinical features. If a patient is presenting with more than age 55 and progressive dysphagia and painless progressive dysphagia is present, so it is a red mark for endoscopy and to rule out esophageal cancer. And the person initially the person is having problem with the solid food, but then gradually it is having problem with the liquid food. Weight loss, if a patient is not intaking any food, so weight loss will be present. Anorexia, bleeding, hoarseness due to the irritation in the recurrent laryngeal nerve. Sometimes fistula is created between trachea and esophagus, and the content moves to the trachea, which leads to coughing, choking, aspiration, pneumonia, pleural effusion, which is a serious complication. Signs are including cachexia, which is a muscle mass loss, lymphadenopathy may be present or maybe not, and the spread can be local extension in earlier stages, hematogenous spread. Investigations can be barium swallow, which we have done in achalasia cardia and very diffuse esophageal spasm, and endoscopy plus biopsy, and this is the investigation of choice, CT, PET-CT for abdominal and thoracic to rule out the extent of disease, metastatic, and the severity of the disease. Ultrasound to see the depth of invasion, endoscopic ultrasound to see the depth of invasion and lymph node involvement. Treatment includes divided into early stages and late stages. In early stages, early surgical resection is possible, radiotherapy and chemotherapy in 30% cases. In the late stages like T3, N1, M1, palliative treatment is indicated. Palliative treatment means to make the death easy, which includes endoscopy, laser therapy, put stent in the esophagus, like esophagus, we will put stent, it will dilate the esophagus, analgesic to reduce the pain, radiotherapy to shrink the tumor, and nutritional support.